had a question, we kind of asked people beforehand what questions they had. They said, where are the sources of stem cells? They can come from a lot of places. Right now, the most commonly used stem cells are bone marrow has kind of fallen off favor, but that's one we've been doing the most research on up until about probably 7 or 8 years ago. Fat stem cells, which is by far the most researched now. And then umbilical cord stem cells. That's where when a baby's born, you've heard of people banking their umbilical cord. And they can use them later on if the baby needs the stem cells. Well, the people that don't want to pay for that, they actually sell them. And we can use it for other people. There's other sources of stem cells too, like the pulp of your teeth, the placenta, and other tissues. But most stem cell research right now is aimed at fat-derived stem cells because it's so easy for us to get. The original stem cell studies were mostly focused around knee arthritis just because it's such an easy target. It's easy to put them into the knee, and knee replacement surgery is so common, so obviously a lot of people have knee arthritis. In fact, knee arthritis has a huge economic cost to our country. Every year, about $16 to $17 billion is spent on replacing knees. $16 or $17 billion, about 1.5% of our health care system. And the people, before they get a knee replacement, they consume an average of $38,000 in medical care before the knee surgery occurs. Physical therapy, injections, MRIs, x-rays, and they wait about 13 years. So they live 13 years. Can we get another little plate of veggies up here? Don't worry about that. People spend about 13 years getting, getting stuff done, trying to, mitigate the pain, maybe getting x-rays done, steroid injections. It consumes about $38,000, and then when you finally get a knee replacement done, it costs your insurance company about $76,000 between the surgery and the rehab and everything. So the economic impact is huge. And we're looking at healthcare. We have a $3.2 trillion a year problem that's consuming 3.2% of our economy, and it's growing at 5% per year. And we're still doing knee replacements, even though we know there's something else available, and I'll get into that. So there's a huge economic impact. In the book, I think everybody's got the book. I wrote about it. I kind of focused on the stem cells, but I talked about the economic impact of this. If we don't embrace this, and we don't embrace change in modern medicine, healthcare is going over a cliff. And we can't sustain a 5% per year growth. The gross domestic product is way lower than that. So I'm going to talk about how kind of the process and how it works. So arthritis, this is a cartoon of a nice healthy joint where there's cartilage, and then there's bone and bone. This would be like an x-ray. And this is an arthritic joint. You can see some exposure to the bone. The cartilage is kind of worn down. And your stem cells that are in there are supposed to be replacing all the time, but something happens, some inflammation occurred or an injury, and they stopped working, so you get arthritis. This is an example of an x-ray. This person looks like they have some kind of a dressing on, but there's a nice big joint space, and joint space is the cartilage. Cartilage doesn't show up in x-ray. We just know it's there because there's nothing in between there, so it's not floating, it's just cartilage. And here's arthritis. You can see the bones are changed a little bit, and there's pressure. This is the lateral portion of the knee, and you can see how this is kind of kinked here. This person is standing with a crooked leg, so they're walking kind of bow-legged, and that's arthritis. These are the stages of arthritis. It's stage 1 through 4. So 1 is just minimal or no arthritis. Stage 2, the joint space gets narrower. You get some little cracks and fissures in the cartilage. Stage 3, the cartilage starts to thin out. More fissures occur in stage 4. That's what people call bone-on-bone arthritis. And that's usually when people start thinking about getting surgery, because when the bone is touching the bone, you've got nerve cells in your bone, and they tell you this is not supposed to happen. You're supposed to have some cartilage. Cartilage obviously doesn't hurt. So for stem cells, we do liposuction. This is a person's abdomen. A little catheter goes in. It's smaller than a pen, and we take fat out. The stem cells are tiny little cells that are bathing the fat. They're all over the place. You have about 10,000 times more stem cells in your fat than you have fat cells. So fat cells die every so often, and a stem cell that's sitting there replaces it, and it triggers another stem cell to replace the stem cell. They can grow infinitely. They did an experiment back in 2006, and they were trying to see how many times the stem cells could replace themselves. So they took one stem cell, and they took a bunch of them, but like one stem cell, they counted it replacing into 1 trillion before they stopped counting. Okay, and seemingly it's forever. So why does this happen? If they can replace forever, we'll talk about that. So we get the stem cells out, and then we do a certain process to separate them, and then we inject them in the knee. Now, one thing that's kind of exciting is we just had made a discovery in science in the past year of changes how we think about stem cells and maybe what's happening. We always presumed, in some degree it's true, that when we put stem cells in the knee, it gets a signal from the cartilage in the knee bone and the inflammation that it needs to grow into cartilage. And we know the stem cells can go from a stem cell, which is basically a baby immature cell, and it turns into a tissue. You know, when you were born, you start out as two little egg and the sperm, and you turn into a double cell, and eventually those cells turn to your eyes and your ears and everything. So we have these cells that are immature that can turn into tissue. And that's what we assume was happening when we injected stem cells into the knee. But oddly, after we injected the stem cells into the knee, people were getting better and growing more cartilage over about a year and a half. Like, how's that? We didn't do the injection other than a year and a half ago. Why is it still growing? What they recently discovered, first through some animal tests, was that when the stem cells go into the knee, they not only start replacing knee cartilage, but they signal the stem cells that are in the knee that are dormant, that aren't doing anything, to do their job. It's kind of like they slap them awake and say, start fixing yourself, because your stem cells have an infinite ability to reproduce. And we used to think you kind of just ran out of them. That was the logic. You must have run out of stem cells. But when they look, they're there. They're just sitting there kind of inactive. And taking stem cell from any source activates them again. Another evidence for this proof was the use of umbilical stem cells. The umbilical stem cells have somebody else's DNA. How do they turn into your cartilage? Well, actually, they don't. They simply get your stem cells working again. They make them operate again. The other sources for stem cell are really not significant. We're doing the vast majority of them from fat. Now, what about results? Well, in the earlier days of stem cells, we didn't know exactly how many to use. We didn't know if we should put them in the joint or around the joint or inject it in the cartilage. We didn't know what the best source was. We wondered where you should get the fat from, what gives you the best yield. So a lot of questions that were mostly unanswered. And in really 10 years of research, 17 if you include bone marrow research, we've gotten a better handle on this. First off, more stem cells seems to be better, but there's a point where you don't need any more. So we know about how much fat to get or how much bone marrow to get. You do it generally one time. One time it seems to get better for about a year and a half, and then you plateau, and then you have nature going on, so it'll wear down. The studies have shown pretty much about 5 to 7 years, you're getting close to back to baseline. So you might do it again. What's the success rate? That's a common question. How often does it work? Well, the largest study, they followed 1,200 people for about 2 years, and they found that over 90% of them got more than 50% improvement. That study, however, was 4 years ago. Since that time, we find that virtually everybody gets a response. In our clinic, we've been doing this for 4 years, and we've only had one treatment failure, and we just did it again. It worked fine. Don't know why it didn't work. So it works with a high consistency. Most people get at least 50% improvement. And then what's happening, has anybody ever seen their x-rays, the bone-on-bone x-rays? They look kind of ugly. The ugliness doesn't change much. What changes is the space between the ugly bones gets bigger. So that irregularity and that ratty appearance of the bone, it doesn't really ever change. So the bone never grows back smooth again, but the cartilage just drapes over it and smooths it out. That way it can grind back and forth. So when you look at the x-ray, unless you're looking really carefully, it doesn't look that much better. But when we look at the x-rays carefully or do an MRI, we can see that the joint space has grown. Other things we've done in the past couple of years is we've used things that make the stem cells grow better. So one thing that we've been doing is we take your blood out and we separate out something called platelets. You might have heard of platelet-rich plasma. When you're reading about this, you might hear about that. By itself, it doesn't do much. But when we add platelets to the stem cells, they make them grow faster, and they stimulate more cartilage formation. And then we use something called hyaluronic acid. You've heard about your doctors injecting something from the chicken's comb. You say the cock's comb, that sounds so gross, but the chicken's comb, it's hyaluronic acid, it's a lubricant. If we put the hyaluronic acid into the stem cells and platelets, it makes them stick to the cartilage better. And we've been doing that in the past few years, adding platelets and adding hyaluronic acid, and it seems to make it work better. How long does it last? Well, there's 3 phases where a person considers doing this again. So one example is early. So one of my surgeons, he's a plastic surgeon that works in the Livonia office, and he has bilateral knee arthritis and bilateral shoulder arthritis. And we did his shoulders and his knees. And he's out here for some training, and he wanted to do it again. I'm like, Jeff, didn't it work? He goes, well, it worked great, and I'm golfing now, but I want to golf better. And his thing was he just wanted to be, more better. But he thought he was about 60, 70% improved. He wanted to see if he can get to 80 or 90. That's the one group. The second group of people, they'll continue to get better for about a year and a half, and they know they're not getting better anymore, and they go ahead and do it again. And the third group of people do it when it kind of wears out. We don't know when that is because there's not been long enough studies following people. The studies at 7 years show you're still better than you were at day 1, but we don't know. There's one study they did, it was kind of interesting. They took 20 volunteers who had bilateral knee arthritis. They looked about the same on x-ray. And they simply said, which is the worst knee? Then no tests, nothing other than this, what knee hurts more? And you can imagine there's always one that's worse than the other. So they only treated the worst knee. And they followed them for 5 years. And at 5 years, the worst knee, of course, was better. But the not treated knee just got worse. So it's like not just healing it, but it seems to heal it and keep it there for a long time. The study is looking at the different types of stuff we use, bone marrow, umbilical cord, or fat-derived stem cells. We see the outcomes are all the same, so we're predominantly using fat-derived stem cells unless there's some reason the person can't undergo liposuction. We just had a case the other day, Dr. Quino did, and the person was on multiple blood thinners, and we were worried about bruising her too much because the blood thinners couldn't be stopped, so we were going to use umbilical cord on her. Otherwise, it's not worth the extra expense. Other questions were like, what other joints can you use it in? The back. So any joint we can get a needle into, we can use stem cells in. The back has got a limitation, is you got to have a fluoroscopy suite. We don't have one. I do have one in our Birmingham office that I might build out and put fluoroscopy there. But basically you do is you put it into the disc and it increases disc space. We've not yet done that. I tried to partner up with different doctors that do back injections, but nobody really wanted to do it. They're kind of nervous about it, but there's 10-year data now showing that it works. Things like pinched nerves, probably not going to work, not the right solution. So if it's a functional problem, can't do it. Another question I get a lot is about, like, people say, well, I had a knee replacement, and they said I'll have to redo it again in about 10 years. Well, if you have a knee replacement, you've got metal and plastic, and stem cells are not going to turn into that, so it's not going to work. And you can't take it out and do it. It's not going to grow a new bone. So once you've had surgery, a replacement can't be done. However, if somebody's had a knee scraping, had screws in their knee, they can get stem cells. One of the videos show was Dennis, and he works here with us, one of our teammates, and he had some cartilage cut off and the screw put in, and we've done stem cells on his knee. So at this time, I want to kind of open up for questions. That way we can more specifically discuss your concerns. So who has questions? Yes, sir.
How long after you get an injection can you be, work again, or
Yeah.
be up and running?
So when you do the stem cell injection, sometimes people have a little pain or pressure afterwards. Not enough you're taking anything, but it'll ache a little bit, especially if it's not that bad. So somebody's got real bad knees, they don't really notice anything else because they're so bad. But people that have this moderate arthritis, it feels ache and stiff for about 3 to 5 days. And typically you'll get a little better for about a month or so because there's a lot of anti-inflammatory properties to the stem cells, kind of getting a steroid injection. And then that ebbs a little bit, and then between 3 and 6 months is when you start getting to where you feel normal. But in terms of taking time off work, not necessary. So whatever you can do today, you could do the day after.
Question right here.
I want to know, why do you think your method is better than anyone else's?
It's not. That's a great question. So why do we think our method's better than everybody else's? It's not. And I've heard this a lot, like, why choose this one or that one? No, just don't choose surgery, okay? The competition of stem cells is not umbilical or a different system to use it or a different process. There's all these companies that make kits. That's not the competition. The competition is a knee surgery, physical therapy, joint injection, steroid injection. So I'd say, is ours superior to everybody else? No, they're your stem cells. In reality, one person's stem cells may be better than another person's, but your stem cells are what they are. So if you're going to choose this, you probably should choose it based on somewhere you want to go, you feel comfortable with. But the guys doing stem cells in our community, they're all very ethical. They know what they're doing. I would say the exception that I would not recommend would be using what's called amniotic fluid stem cells. Not that it's bad. There's no published work. So we don't know. So we don't know that one. But some guy's doing umbilical, that's fine. Okay, that's fine. Somebody's doing bone marrow. You don't get as many, it's still fine. The alternative that's not acceptable is getting your knee replaced. Yes, sir.
You said I saw you had Dennis up there. You said he's part of your organization or your group?
He works here.
Is he here tonight?
Yeah, you can talk to him afterwards.
Hey, Dennis, how you doing? There he is. I know Dennis. Oh.
Are you new?
How long have you been doing this?
So in 4 years, my brother was paralyzed from a spinal tumor. And we were at Christmas. He said, I'd like to be able to walk again, ride a bike. Like, it ain't going to happen. So I started researching stem cells, and the Koreans had really been active in it. We weren't doing much in America at the time. So I learned about it, traveled out, and got the equipment. And I treated him. He got better. He went from basically being incapacitated to being able to walk. He didn't walk normal. and I treated him 3 times. He was shuffling. Spinal cord disease is much harder to treat, but he was shuffling, but he walked without assistance. And interestingly, I saw him at my daughter's wedding a couple weeks ago, and he was back in the walker. I'm like, what's going on? He goes, I think I wore off. It doesn't ever wear off. And that was a red flag. I sent him for an MRI. He's got bleeding from the prior surgery, so he's going to get that fixed. But it doesn't wear off for spine. It does wear off for degenerative stuff.
Okay.
So we've been doing it for a few years. Yes, ma'am.
I want to ask you about, then, if you can put stem cell or anywhere, like in the neck, for arthritis in the neck, that when you can't move it?
Yeah, that's a good question. Can you do it for the neck? It can be done. We can't do it. We don't have the x-ray equipment. And then some people, when they have neck problems, they might have a cord compression. And if it's like real severe, you got to get surgery to decompress it. But that's going to be something that'll happen, that we'll be injecting stem cells into the disc to raise them up again.
Okay.
So unfortunately, we can't personally do it here, and there's nobody in the Midwest doing that. Got to go to Panama. Yes, sir.
Okay. Someone have a
Yeah, we have a question
Okay,
over here.
sorry.
Yeah, is it covered by insurance?
Yeah, this is kind of cool. So I'm going to make like a joke about something, okay? So, you know, like, say Mississippi, and Mississippi is like a poor rural state, and they always say like Mississippi is like 49th in education, and 49th in literacy, and 48th in teen pregnancies, and their motto is thank God for Arkansas, right? And so here all week. So I said that one today at our meeting. So Arkansas, the state of Arkansas, the governor signed a bill 2 weeks ago covering state employees for stem cells. First place in the nation. And what happened is, what's cool about that is it's like a domino effect, because nobody had the boldness to actually do this. And it was interesting, one guy he knew was the doctor that did stem cells, and he treated them. And it's like, the economic impact of stem cells is enormous. You know, when we learned how to regenerate our own bodies and make disease optional, it's enormous. But healthcare is amazingly biased. There are so many self-appointed guardians of the past that a lot of doctors are very resistant to this occurring. I was at a dinner, at the men's night out at McLaren Macomb Monday night, cigars and alcohol. So I got some talking to guys that were kind of liquored up. And the orthopedic doctors, I'm talking to them about this, and they know about it. And the common line was, I just hope this never catches on before I retire, because they're afraid to change. They're making money on joint replacement. It's freaking amazing. And that's sort of a normal bias, that I don't want it to be taken away, like the world's so scarce that there's not other shit to do, you know? Yes, sir.
So I know you said you started with your brother and around 2000. And I have multiple questions. How intense has this become at Allure in the last, let's say, 4 years? Are you performing substantially more of these from 2012 to 2017 now?
Yeah, that's a great question. So
you said you started this quite a few years ago. And the other thing is I think when you're doing, is this FDA approved?
yeah, those are all good questions. So first off, the FDA cannot approve a procedure. There's no such thing. They can approve the equipment, so we have FDA-approved equipment. And there was one thing that we were doing that was kind of flying under the radar. We were doing the first way we were doing, we were using a medicine called collagenase to free up the stem cells. And the FDA had made some positions that they weren't sure that we were making a drug or not. And they may consider, do they have to get involved and decide if you're an FDA-approved lab, which we're obviously not. So when that happened, it kind of put some restrictions on it. I was invited to speak on CBS National News. We were actually one of the leaders in stem cells for several years. I was asked to speak on CBS National News to talk about stem cells, and I didn't want the attention, because the FDA was saying, like, we're not sure, we might start investigating and see whether or not this is actually a drug. Well, in the past year or so, we figured out how to do it without the collagenase. So now it's not an issue. It's just a surgical procedure. So stem cells may eventually be FDA approved, and what would happen in that case is the doctor would buy a drug from a company that's got somebody's stem cells in it that are kind of neutral, and they'll give them to you. That might be 5 to 10 years off. So right now, stem cells are pretty much done from your own body, and the FDA has no jurisdiction over you. Okay, so it's like if you had your appendix taken out, FDA doesn't approve that. They don't approve an appendectomy, and it's considered a surgical procedure. And you're saying is it more common now? Well, now that it's like easier to do, we've been able to lower the price. We are doing a lot more common. We were actually doing quite a few from the onset. We were initially involved with about 120 doctors doing 11 clinical research studies. And we treat everything from MS to strokes to Alzheimer's, I mean, just everything. So we've had a lot of experience. Everyone's focusing on knees now because it's like an easy target. People understand it, and the economic impact of knee replacements is so high. But we actually treat multiple conditions. Let me just grab a question over here.
So I heard you earlier, you said you use platelets, you use hyaluronic acid, and you use stem cells, and you mix them together, and that's what you inject?
Yeah.
Okay, just want to be clear.
Yeah, so hyaluronic acid is the thing that you normally use for arthritis. And they did comparisons of hyaluronic acid versus platelets for people with just knee pain. That platelets work a little bit better. Then they combined them, and in people that have minor arthritis, actually that's as good as stem cells. So stem cells are for people with more significant arthritis, and then we use all three.
And we have questions?
Once you have the procedure, do you have, as part of your program, a follow-up to demonstrate that it actually worked? Now, how do you know if you don't have pain, but you have a problem, how will you know it, maybe in my case, meniscus, has it grown back? How do you know it's actually happening?
Yeah, so the vast majority of people have pain, and it's the absence of pain. That's how you do. But if somebody has a meniscus injury and they want to see, you'd have to do like an MRI or a scope. Now, it's not necessary to do that because the research has already proven that it's done. But if somebody had curiosity, you probably just pay out of pocket for an MRI. Okay, so there's really no, like, you can't do an X-ray, but the MRI are actually putting a scope in there. Is there like other tests that you do? The answer is no. You actually have to look at it if you want to see because it doesn't hurt. Okay, so pain is the usual one. Yes?
Do you use an antibiotic before doing the procedure?
Yeah, definitely not. Okay, antibiotics are so grossly overutilized, they're killing us as human beings, so we stay away from them.
What if you are a chronic kidney patient?
You still don't use them. This is a clean procedure, so antibiotics cause harm. This procedure has never been associated with infection, so it's inappropriate, even if somebody with risk. The only time we would do that is somebody's got a heart valve, and then the skin back because you're doing a skin procedure. So kidney would not be, that kidney patients really should stay away from antibiotics as much as possible. You had a question?
Did I understand you to say that once you've had a knee replacement, that you cannot use stem cell for any improvement in the future?
Yeah, because the knee replacement is steel and plastic or ceramic, and stem cells won't turn into that. They only turn into cartilage.
That's on your existing knee, not your other one.
Oh yeah, you could treat the other knee.
I had a knee replacement, that's what I was just asking.
Yeah, the one knee replacement, when that wears out, it's got to be replaced with a knee replacement, but you could treat the other joint.
Right.
And you had a question up here?
I do. Does it interfere I have venous stasis, okay? I've had an ulcer, swelling in the back of my knee, and I've also had some blood clots. Does that interfere with any of that?
It doesn't, but I wrote a book on that. So can you get her a copy of the main book, venous ulceration book? And we treat that. I actually did the FDA study for a thing back in '06 that treats that permanently, cures it, never have an ulcer again. So that was kind of exciting years ago because that was cutting edge, and now we do about 20,000 of those a year.
Really?
Yeah.
Can the procedure be done for shoulders?
Yes. Yeah, that's the one Dr. Aquino loves doing, the shoulders. So that's a cool one.
How about a maintenance program? Is there one required?
Yeah, so we don't really know that, okay? So that's a great question because I would wonder, what happens if you did the stem cells? Oh, I'm sorry, question was, is there a maintenance program? What we've discovered is that we can grow stem cells. We can grow them. And there's a procedure, it's called extracorporeal shockwave therapy, and it's like a little hammering thing that they use for treating kidney stones. And we use it for other conditions. And they've done studies showing that this stimulates and activates your stem cells. Now, when they did a study on people with severe arthritis, it didn't cure their arthritis, but people with really minor arthritis, it did. And I'm excited to see, if we do stem cells, can you come in a couple times a year and do this external thing without a shot and keep it going, keep it stimulated? Don't know, but that's really exciting. I think what's going to happen very soon is that we're going to figure out how to waken your stem cells up that are in your body without sticking a needle in you. Okay? Yes, sir.
So you answered the question, basically said the procedure is not FDA approved, is what you said. You've done some of these. Let me ask you, if you've been involved in this for a number of years, can you give me some input, positive, negative? Have you ever heard of the MACI program?
No.
By Vericel?
Vericel, yeah.
Okay. You've never heard of them? The FDA approved MACI for the treatment of cartilage defects in the knee. It's a stem cell thing. I would suggest you look into that.
No, I'm not using that because there's actually about 24 companies, and we really don't need to. So what happens is if you send it to a lab and they send it back, it's got to be an FDA-approved lab. We just do it here ourselves. When we use umbilical stem cells, there's some that go through the FDA approval process and some go through the Red Cross as a blood product. So it's really not necessary to get an FDA-approved product. You can actually use your own stuff. Okay, so there's nothing wrong with that. Like I say, anybody's doing stem cells and you want to do it, that's fine. The competition is the knee replacement, not where you get them from. But here's the way it works with the FDA. If it leaves our office and goes to a lab, it's got to be an FDA-approved product. So companies have been doing that. You know, you heard about Gordie Howe. He got his stem cells taken out in America, made into nerve stem cells in California. He had to go down to Mexico to get them, but now some labs are getting approval here. So that would be an idea, is that you start growing them. And one of the things that's going to happen, like you say with these companies doing, I'm not familiar with Macy's, I know all the other ones, but what they're doing is actually expanding them, where you can actually maybe potentially we get like a teaspoon of fat, send them out and grow it into a bajillion, and then you can get it as needed. So that's coming. That's coming. Right now, we're not doing that because it's really sometimes cost prohibitive. You're dealing with an FDA lab that's maybe going to give you some problems getting it on time because we want to do this kind of fresh. So other than umbilical stem cells, we're using your own. Yes, sir.
There seems to be a large variance in the cost of the procedure. Is there a reason for that?
Yeah, so it's coming down fast. When we first were doing this, labs down in Panama, the biggest one's been Panama. It's Dr. Rorden has been doing that. I can't remember the name of their company. It's about $25,000. And it was just like nuts, but they were doing a complex process, separating them out. Then there was clinics started opening in the United States doing bone marrow, which was a little cheaper, but still there's some costs associated with, giving you the anesthesia. Now we're doing fat. It's coming down very fast. I think we'll probably get it down to where we're seeing this being, well, covered by your insurance, but eventually it might be lower than $1,000. Right now it's not because of the complexity and cost involved. But the variance is because the prices are dropping fast because we're figuring out how to do it faster, easier, cheaper. I mean, really a year ago it cost us $3,000 more than it does today. That was our cost more. I mean, that much more. Yes, sir.
Yeah, I've got two questions. One is, what additional training do you have to do this?
So,
The other is, how long does this procedure take to do?
Okay, so first off, a lot of it I already had training for because I was doing liposuction already. That's why it was easy for me to do that. I also used to work in the trauma center, so I was comfortable injecting knees. So that part was the physical training I already had. But we got training through the California Stem Cell Network, and there's about, like I say, 120 doctors involved with this. So we just had regular trainings, did on-site trainings, live person trainings. There's no residency training anybody for this right now. So really everybody's getting trained outside of universities and hospitals. There's probably about 24 training centers in the United States for it. We just joined this one in California. And again, I say the real message is I'm hearing about using this product or why the price is different or where did you get trained. Everybody in Michigan doing this is working on improving your health. And if you're doing it somewhere, go someplace you're comfortable with. But the competition or your decision is not between the different places. That's the choice you make. Even when we talk about umbilical or fat or bone marrow, they all do work. The flip side is then when you know this, don't replace your knee. This is not necessary.
How long does the procedure take?
I mean, it depends how fast we are, but it takes probably about an hour.
Now, is that removing the fat separate and injecting it, or is it a 2-day?
Yeah, well, let's talk about the process again, okay? So the process got simplified. It used to take us about 4 hours. Now we can do it in about an hour. But we liposuction fat out. We get about 10 teaspoons. 10 teaspoons of fat. Then we use what's that? You spare it? Okay. Yeah, I gotta come here and get some cheese and make a little. So 10 cc's of fat, and we use one of a few processes. Again, they're FDA-approved equipment. So one's using an enzyme and an incubator and a centrifuge, and that's kind of expensive. Now we're using a device that basically macerates the fat. It's got a series of screens that breaks it up. And then the stem cells are heavier. They just weigh more. And because they're heavier, they will fall to the bottom. And then we spin them in our centrifuge, and they fall to the bottom, and we separate those out. After that happens, we add the platelets, which is done in a similar fashion. We draw your blood. And we spin it. The platelets are a little bit lighter, so we collect them off the top. And hyaluronic acid is already kind of available. And we just put them together and inject them.
What's the time period?
Like I say, about an hour. I mean, it might take longer, but it's about an hour.
Yeah, what about infections? Can you get an infection? You know, you're injecting a needle and...
Yeah, I mean, it's not really been reported, but I suppose it can happen. I mean, that's a warning. We say, yeah, you can get an infection. But has anybody ever had their knee injected with anything before? It's the exact same rate of infection. It's like this doesn't really, it's not something that's known to occur, but we always warn you, yes, you can always get an infection if you're getting a needle stuck in something, but it really is because it's a needle. Needle picks for blood tests or IVs, very low risk of infection. So the same as whenever you did it before, it's kind of like you're sticking a needle in there, and I've never seen it reported in the literature. Yes, ma'am?
Is there such a thing as
good or bad fat?
Yeah, and that's a question that we've always wondered. And like the fat inside your gut that gives you like the belly fat, that's actually an inflammatory stem cells. And of course, nobody's using those. You can't get to them. But in general, when they've done studies looking at different parts of your body, there's not any significant difference. So usually we say, where do you want to get rid of fat? You had a question here?
Yes, I have to ask this question. It's a little complicated. I know
I'll give you the mic.
the bone marrow transplant bank does not actually accept anybody past a certain age because it's risky for the fact that the stem cells that are older, when they replicate, sometimes have problems, okay? They don't actually replicate as well as younger stem cells, so they don't accept anyone but younger people into the bone marrow bank.
We're not talking about donating your.
You talk about fat, your stem cells, and they divide and reproduce. So I have a lot older stem cells in my body than some people. So is it true that possibly my stem cells would not be as effective at solving my problem as if I had some from a cord or something?
Yes, a cord stem, okay, that's a great question. What happens is as you get older, your stem cells are getting more tired. They've already reproduced themselves maybe 1 trillion times. And what you're talking about is where you're trying to give bone marrow to another person that's dying of cancer, you would want the healthiest possible stem cells available. You're already getting it from another person so that you have communicable disease is not an issue. But we're not banking this and giving it to somebody else. You're using your own. Okay? Now, the question is if you're an 80-year-old person and you took stem cells from a baby, would they work better? Yes. The inherent problem is that, first off, we can't do that. You can get umbilical. Secondly, you go through the cost of trying to get all the red blood cells out. And thirdly, there's unknown communicable disease risks. So it's not practical. Okay? The flip side is if somebody's really sick and they don't have any fat, we would use umbilical. And they test it for herpes and AIDS and hepatitis and something like that. But that's the risk of using somebody else's. Another thing that's a very important point. When you're banking your stem cells, you're trying to save somebody's life. We're trying to make your arthritis go away. And going from a fat stem cell to cartilage is a very easy process for a stem cell versus going from a stem cell into replacing all of your white blood cells, red blood cells, platelets, B cells, T cells, much more complex process. So we're looking at blood banking for people that are dying of cancer. This is a much more complicated thing than telling a stem cell to grow into cartilage. So from a realistic standpoint, doesn't matter what age you are, the stem cells work in the joints. So it's just not necessary from that standpoint.
Question, Karen?
Yeah, my question is, if you say you have a little bit minor arthritis, because I think everybody has some, even younger people, and they have an injury where they tear their meniscus, is that going to help you any?
So there's not been a lot of research into young people with meniscal tears until recently. Now when they're doing meniscus surgery, they'll actually do a bone marrow stem cell while they have you on the table and put it in there so that they're using that. And orthopedic doctors are really comfortable with getting bone marrow stem cells. And because it's a meniscus tear and you're injecting in it, they don't need many. So that's typically what's happening is a lot of orthopedic doctors are not comfortable getting liposuction. So the answer is yes, that's already kind of happening. And that's been going on for a few years now. So meniscus tears, getting surgery done, stem cells are common. Even like when people are getting fractures fixed, they're commonly taking some of the bone marrow out of the fracture and putting it into the bone when they're fusing it back together.
The machine that does the separation, how much does that cost?
I would guess that, there's a bunch of systems available. In reality, you could probably, eventually I think we'll be doing this for almost nothing. We did an experiment. We haven't used it on people yet, but we did an experiment taking a 3-way stopcock, and I just gated it so it was really tight and ran a syringe back and forth. And I put it in a regular, cheap $300 centrifuge and spun it, and I was getting stem cells. Not very many of them, but I'm thinking it's coming, to where we're going to have this like really cheap. But right now, we probably got about $50,000 invested in equipment. It's not a big investment. My laser tattoo removal machine was $350,000. It's kind of a piece of shit. It doesn't really, it works, but that's it's broken all the time, and we got to get a warranty on it. You got a question up here?
Yeah, did I understand you correctly? You say that you get injections in your knee for arthritis that it can heal your meniscus if it's torn?
Well, so if it's torn and flapping, it's not going to glue it back down. So typically we'll do it, what they do now is they kind of shave it off. What doctors are trying to do now is put stem cells in and kind of pin it down. I don't really have an answer to that because nobody's published papers on that. Okay. Now the flip side is there's a condition called osteochondritis dissecans, where instead of the meniscus being torn, there's a hunk missing, like a postage stamp type hunk missing. And there was a few case reports where they just said, hey, this seemed to work. But what they found is that when you have this hunk of cartilage missing and you put stem cells in, it grows it back like it would never happen in the first place. Will it lay a flap down? Don't know. Nobody's ever written on that.
Did I hear you correctly? You said something about that this doesn't work for degenerative joints or wears out?
No, it does work for degenerative joints. That's basically what we're treating is degenerative joints.
Okay.
But the degenerative joints occurred by your walking mechanism and the way you do your sports. So somebody that has degenerative joint disease, it's degenerated. So if we get it better, you might expect that 3 years, 5 years, 10 years that you've redegenerated it. Maybe the same condition occurred again. The studies are not long enough to tell us when you go back to baseline, because the longest study has been 7 years, and people still weren't back to baseline. So the answer is how long can it potentially last? We don't know. We know a knee replacement's got a lifespan on it, and that's kind of known because we've been doing knee replacements for decades. But for stem cells, we don't really know how long this can last. And we don't know things. What happens if we do other things to keep them growing? Can it last forever? Don't know.
Will adipose stem cells also help someone who has a Baker cyst?
Yeah, it will not.
It will not.
No, Baker's cyst is actually a misnomer. It's actually not a cyst. It's just where your knee synovium just kind of blew aside. It's more like a diverticulum. So there's nothing to do for those. That's just a sign of arthritis, but it's not really a fixable thing. Your question up front?
Right.
Yes, ma'am.
Yeah, I'm sorry if I missed what you said after I told you all that was going on with my leg. But am I a candidate for the stem cell for my arthritis in the knee with all that others, the venous stasis, the blood clots, the blah, blah, blah?
Yes, that's a great question. And we would, on consult, tell you that specifically, but the venous stasis or other conditions is not a reason not to do it. So people are candidate based on their arthritis, but there are not conditions that prevent you from getting it. There are not known conditions that prevent you from getting it.
Okay.
Yes, sir. The answer is yes.
Do you do all the stem cell procedures, or do you have other people too?
You definitely don't want me doing it, okay? So I'm like the scientist and the innovator, and I'm very rough, right? So we have nice ladies that are doctors and physician assistants that do everything. You know, my joke always was like, will you do my Botox? I'm like, look, lady, I'm gonna put my knee on your chest and hold your hair, you know. Yeah, and not a good idea. Yeah.
Questions back here?
Yes, ma'am.
And someone on blood thinners.
Yeah, so on blood thinners, there's different circumstances that we do. In general, we've treated people on blood thinners, but they do bruise a lot. Somebody who's on blood thinners and high risk for bleeding, then we would use the umbilical one, so there's no issue. The needle's not going to do it, it's going to be the lipo.
I mean, someone had a valve replacement, so you're on warfarin.
Yeah, so that person that we might use umbilical stem cells on. Question in the back?
I apologize if you talked about this earlier, but where do you source the umbilical stem cells? And I thought that was prohibited, by
Yeah, that's kind of like one of those things that is a legacy in our minds. We think about embryonic stem cells. So the embryos, with the controversy is they were, offering women to abort them for free to take the embryos. In the first George Bush presidency, he outlawed that. And then that's been outlawed since that time. We still have the embryos. They've got it at Michigan, University of Michigan. They keep replicating them, so they were allowed to continue. You just can't use them on humans. And where is the umbilical sourced from? It's sourced from mothers that don't want to pay for the stem cells. They actually buy them from them. We get ours from a place called Liveyon, L-I-V-E-Y-O-N. And it's considered a blood product. So again, there's all this question about the FDA. FDA does not regulate blood products, regulated by a different agency, and they are approved. And they're pretty easy to get now. That's getting pretty common.
More expensive?
They're more expensive. Yeah. Yes, sir.
Dr. Mo, now, I'm told that I've got the arthritis, and I take hydrocodone 3-4 a day, starting in the morning, whatever, for the pain, to help the pain, and I can stay mobile. With the use of my cane, longer distances, I use the walker. Okay. But what it is that my right side of my body is worse than my left side of my body. My knee joint will give me trouble, depending on, like, predicting the weather. Low barometric pressure comes, and I have the hip joint. when it's really pain, the pain in the knee and the hip are not as severe as like the muscle in the center of the thigh here, okay? And I'm told this ties in with the back also. Now, okay, am I treatable with stem cell, or do you need to see to the extent of where my damages are with an MRI, or?
Yeah, and that kind of complicates thing. You'd have to see us for a consult. So we possibly tell you here now. So for example, if your pain is because the nerve is pinched, it really won't work. So that's something you have to have a consult. We probably want to look at your records and stuff. So I can't answer that question at the seminar.
So I'd have to make an appointment?
Yeah.
And then?
Bring your records.
Or with my general practitioner, or?
No, through appointment with us, with your
With you,
records.
with
Yep.
my records?
Yeah.
With full access to my records from my general practitioner?
Yeah.
Because I've had response with physical therapy in the reduction, but if I don't stay with the exercises, I'm right back hurting again.
Yeah.
And as you hear from all the people with bad arthritis, that we're a good low barometric pressure, the lower is, we know the storm is coming.
Yeah.
Because we ache like the Diggins.
And you live in Michigan.
And we live in Michigan. You know,
Yeah.
so-
Got a question back here? Yes, sir. You had a question, or we get you?
I was wondering if you have follow-up check with patients a year and 2 years afterwards to see what their pain level is. And if you do, it sounds like there's a lot of potential here and stem cells works well, but what percentage of your patients would you say have less than 50% pain reduction after a year, for example?
Yeah, it's over 90%. That's a great question. So we were used to be in a clinical study. We had a certain formula with some third party was calling them. Now we're doing it ourselves. And at 2 years is when people they stop getting better and they can feel it going back a little bit. So it's 1 year, it's over 90%. At 2 years, it's right about 90%. And then after 2 years, it starts dropping down a little bit.
Over 50% improvement?
Yeah. Yeah, over 50% improvement. Mm-hmm. Yeah.
And who did you say is the ideal patient to have your stem cell procedure?
Who is the ideal patient? Somebody that's considering a knee replacement would be an obvious ideal patient, because that is, from an economic standpoint, a huge problem. It's risky. You go knee replacement's got a 2% more major morbidity, meaning you have 2% chance of getting a blood clot or heart attack or stroke or some major complication. So that's really the ideal patient. That has such a huge impact on our country. Now going back from there, somebody with more mild or moderate arthritis, other people are thinking about it. Because once it gets so bad, they're already in the healthcare system and are preparing themselves mentally for a knee replacement. So we're seeing people that maybe they're starting to talk to their doctor about getting a knee replacement. I think in 10 years, we'll probably be getting people much sooner than that because it's more aware of it. But usually people are coming in here because they say, I got to do knee replacement. I don't want to do that. I don't want the surgery.
I guess what I was reading up to is if you do have Baker cysts, if you do have torn meniscus, can you still have the stem cell procedure and hope for a good outcome?
Yeah, that kind of stuff doesn't matter. And they've done studies where they look at, what about the stage, I'll show you that stage 4, which is the worst arthritis.
Right.
They had the same response as the people with mild to moderate arthritis. So the degree of arthritis does not seem to matter. Yes?
That's very encouraging.
My sister was just to her doctor yesterday and just trying to talk her into a hip replacement. Could you say a little bit about hip replacements and what percentage you do and how those work out compared to knee?
Yeah, so is it for arthritis or a different condition?
I'm going to say it's arthritis, yes.
Yeah, so there's more data on knees than hips just because there's more common. But studies on hip replacements, ankle, shoulders have shown the same results as the knee. The downside of the hip is it's a tighter joint and it aches afterwards for a few days. It hurts. And it's harder to get into. So mechanically it's harder. It does hurt more, but the response rate seems to be the same.
So would you need like an MRI to see before you do a hip or
an
I know
X-ray.
you don't for a knee, you just shoot. But
Well, we would do like an X-ray first, typically for knee or hip or anything. I mean, you want to identify that that's actually the cause. Because there's other reasons for hip pain. There's something called avascular necrosis. There's blood clots. There's different hernias. So we want to know, do you actually have arthritis? With some confirmatory tests. But in terms of what tests you need, it doesn't really matter.
Do you do both knees at the same time? Can you do that?
Yeah, that's common. And one of my best friends, he's a cardiac surgeon in Missouri, and he was out here and we did his knee. I said, Colin, let's just do both. Why not do a preventive? He goes, the other knee's fine. And he talked to me like 3 months later. He goes, shit, I didn't know my other knee hurt. Yeah. Any other questions? Yes.
I get those shots. I was getting them every 6 months for
Yeah.
a few years now. And just recently, they haven't been working. So this month ago, I went and got the shot. Then they had to give me cortisone. Then I have to go back in 3 months and get cortisone again. Are you able to fix something like that? I mean,
That's the most
my knee
common.
is popping again.
Yeah, so the most
So it
common
doesn't
person
matter.
getting this done is this stuff's not working anymore, and they start seeking something besides the shots. So when the shots of hyaluronic acid are working, that's probably fine. It is continuing to wear down. It gets to a point where that's not working, then you do something else.
Does that consider like moving somewhere where I could golf all year? Because the golf course does not bother me.
That's good.
Believe it or
Yeah,
not.
that's great. Yeah. Yeah, so you could still do stem cells, and the timing of cortisone doesn't matter.
And he doesn't do knee replacements until you're 80 years old.
You know, the reason that she said they don't do, this guy doesn't do knee replacement until you're 80, and the reason is, you know, we're living a long time, and you do a knee replacement, the clock is ticking. And the second time you need a knee replacement, it's a mess. It's very hard to do a redo knee. So they don't want to ever do it when somebody's 60 or 70 years old. They're going to live to, you know, 80 or 90. So that's one of the reasons of pushing it out, is that the second surgery is a real problem.
I told him, I said, by then I would be walking anyway, so.
Well, we're living longer, and the you know, conceptually, we might eventually be able to make disease optional. You know, we're looking at,
Or it pops behind the knees now, too.
yeah.
It catches when I get up in the morning.
What other questions? Yes, sir.
My primary issue is really my torn meniscus. And my minor issue is just a little bit of early arthritis in the same knee.
Yeah.
So would I be better off to get the meniscus repaired first?
You know, if the meniscus is torn and it's not your knee's not lacking, it would be reasonable just to do stem cells first.
No.
Okay, because when they cut the meniscus out, now you're just asking for accelerating arthritis. It's kind of a surgery that never really did real well. And the people that have meniscus tears where they're having a knee catching, that's what I was talking about. Does it glue it back down? We don't really know. But usually when it's torn, there's just a tear in it, and the cartilage has very little blood supply, so it doesn't heal. So this would theoretically heal it back. And they've shown that it does do that. The issues I was asking before, I said before, they don't have studies showing if somebody has a knee dysfunction where it gets locked because the cartilage just keeps peeling back, we don't really know in that case. Yes?
What about the arthritis? So I've got osteoarthritis. One knee's worse than the other.
Yeah.
But when he gave me the shot the time before, 6 months before that, he said, I told him, I said, you gave me the shot, and I said, it really was painful, it hurt. And I said, now I got a knot on my knee. And he goes, no, that's from the arthritis.
Yeah, so that's where, when we're talking about the degenerative arthritis and osteoarthritis, those are the same thing.
They can be fixed.
But they're both the same thing, yeah. So we call it osteoarthritis, which is different than rheumatoid arthritis, meaning that it started out in the knee, or we call it degenerative arthritis, which is a more common term. So they're both used. So we're going to have an opportunity to see some of the doctors and providers, and if you want to take that over and explain what the plan is.
Yeah, thank you very much.